This winter, more than ever, with COVID-19 still circulating, we need help to reduce all avoidable risks. You can help protect the NHS, social care and loved ones by getting the flu vaccine. You may be eligible for the free vaccine at your GP or local pharmacy if you are over 65, pregnant or have a long-term condition. Find out if you are eligible at nhs.uk/staywell. Children up to Year 7 can get the free nasal spray at school or through their GP if they are below school age. If you are not eligible for the free vaccine, you can pay for it at your local pharmacy. The flu vaccination does not give you flu. It reduces the risk of catching flu, as well as spreading it to others. If you had the vaccination in the past, that will not protect you as the flu strain changes every year, so you need to have a new one this year. It is also important to wash your hands often with warm water and soap. Use tissues when you cough or sneeze, and bin used tissues as quickly as possible. Thank you for helping to protect yourself and loved ones this winter.
I can really recommend being a foster carer for Notts County Council. There's always someone walking the journey alongside you, whether that's other foster carers or social workers. It really helps to provide stability and consistency for children who really need it, and that's really rewarding as a foster carer.
Roger and I have been fostering for 35 years. We do deal with challenges, but to say we've been doing it for 35 years to me proves that it's not impossible. We learn an awful lot from these young people, and even now we're still learning.
As a foster family, we care, we want to make a difference, and we get so much fulfilment from fostering. The satisfaction of making a difference is something that money can't buy. Just seeing the smiles on the children's faces and helping them reach their potential is wonderful.
We work as family workers within the fostering service for Nottinghamshire County Council.
I really enjoy my work. I really enjoy meeting lots of different foster carers.
You know, we get to know the families, we get to know the kids, and we care, basically. It's important as it is to them that the kids are getting the support that they need.
A lot of people said to me they would like to be a foster carer, but there's something stopping them. I had that as well. And we decided just to jump in and do it and see what happened. And for us, it's been the best decision we've ever made.
It's been a fantastic decision, it really has, yes.
Once people start to become a foster carer and take that leap to do it, they'll understand how much it gives back, not just to the child, but how much it empowers you as well.
I'm Leon, I'm a care leaver, and I've been in care since I was 8. I've been with the same parents since, and they're amazing. Like, they are my foster parents, but I do class them as my parents, my mum and dad. All a child wants really from a family is to be supported, loved and cared for, and know they're there because they're wanted. From personal experience, I know the difference it's made for my life.
We always say that we foster as a whole family. It's not just us who are the carers, our children are involved in that. And even now, people express concern about the effect on our birth children of foster caring. I think we need to kind of get past that and dispel that myth, because actually the overall effect on our children, I think, is positive. They're learning new skills, they're gaining empathy, they're interacting with children from different backgrounds. For a long time, we didn't make use of support care, and we wanted our child to settle into our placement and not feel pushed out, but it's actually been really helpful for us to start to have support care. We've
known Zoe for a number of years, and it's meant that we got to know her foster child. So for her, it's been like coming for a sleepover rather than a feeling she's coming to another family. I got into fostering for Notts County Council, and it was something that I've always wanted to do. But working full-time and my husband also working full-time, we thought it's not really going to be something we can do now. But after looking at the website, we realised there was this wonderful thing called support care that we were able to offer. It might surprise you, but actually I'm under 30. I don't have any children of my own, and that doesn't stop you from being a foster carer.
I think some people don't go into foster care because they think it's going to be really costly to have another child living in their house, but actually the fostering allowance is generous enough to cover all the costs of having a child living with you.
We have a lot of fun on the weekends when we have foster children in. We get to go to parks, ice skating, children's events, trampoline in parks like I Jump.
We get access to the Max card, which is a discount card for foster carers and their children to access different local amenities. Also recently we went on holiday and we were able to use the Max card to get free access to some castles and historical places because it's a national initiative.
We chose to go with Notts County Council because of the support care that was offered and the training. And it's always local to Nottinghamshire. My parents are foster carers for an agency and they found it really difficult to get support care for their child.
My name's Lynn. I am now a support foster carer. We were mainstream carers, but given our ages, we felt that we couldn't commit to children for long terms anymore. We just find it really rewarding, the relationships we build up with these young people, and we feel we're perhaps a bit like grandparents to them. With the children coming here for weekends, this enables their mainstream carers to have a break, and this makes things more secure perhaps for the children to continue there. I work with my supervising social worker to sort out the dates. She comes out to see us every month and it's all very relaxed. I find Robin really easy to speak to. She listens to my concerns and I value what she is saying to me in return.
The benefits of a supervising social worker are always having someone to contact. There is also emergency duty team that they can contact on a weekend and out of hours. I think the times that it gets difficult is when, she's supported a child for a long time and then they're either moving on out of area or they're moving on because they've reached the age of 18, and she has to say goodbye to that child, so that can be always emotionally draining. Generally it's staying in touch so they know that you do care about them and you are concerned, that the impact that something like that has had on them.
You do feel fully supported. It's like working in a team. We still even now go on training sessions. I almost look forward to those sessions because you meet other foster carers there and it's very interesting. I've always fostered with my husband, who's brilliant, and I feel personally I couldn't do it without him. He's super with the kids and it's just something we continue to enjoy doing. A lot of our friends feel at the ages we are, we shouldn't be doing it, but it's a way of life for us now.
I'm Mark, I'm a foster carer dad in the family. I'm the fun dad, if you like. I've tried to be anyway,
And I'm Amy, a foster carer. So we have 4 children of our own and then we foster younger children into our family. Being a foster carer is a devastating privilege. It's devastating that children have to be in this situation, and yet what a privilege that we are able to help them. Yeah. When you foster as a family. I think it's very important that everybody in your house is involved, and even though we have 4 children of our own, we don't find that a challenge, we find that quite an easy thing to do. Daniel particularly, he's older and he sees more and he understands more because he's older, and he feels that it's given him an insight as to when he's older and he has his own children. Whenever a placement ends, we always ask them, do you want to do it again? Would you like another child? And it's always yes. And even though we've had the sadness maybe of a child leaving, and they are sad when a child leaves, the positive that we get out of it, they get to see, as we do, the happiness when a child leaves us, and that inspires them as well to want to do it again and again and again, as well as us.
When a child leaves, it's sad for us, but it's happy for them.
The biggest thing for us has been the support network, because if it wasn't for them, I don't think we would be able to carry on. I think it's a big thing to know that there's always someone there if you've ever got problems. And for our children, they really enjoy the events that we attend. We've been quite surprised at actually the amount of events there are.
Barbecues and picnics and
local supports
groups. And Foster's Got Talent. We've been to the Christmas do's and the Sons and Daughters events here today are fantastic for our children. They really enjoy it, and I think it's a lovely thing for them to do.
And it's very empowering for them to know that they're appreciated as a child in a foster family.
We are allocated to new foster carers so that we can give them support and advice before they get their new placement. So we might go out and give them some advice around therapeutic parenting and kind of build up their foster carer toolkit before they begin.
Yeah, and we've got an idea of obviously the child who's being placed with them, so that we can tell them some background about that particular child.
We find that children that have experienced trauma or have attachment needs are more responsive to therapeutic parenting than your average parenting. So that's very much what we encourage our foster carers to do.
Theraplay is obviously a form of therapeutic parenting. A lot of the foster children, their early life experiences of being quite sad really. They haven't had any compliments, nobody's ever said that they've got nice eyes, nobody's said that the hair's nice. So that is something that we always start off to build their self-esteem.
Yeah, there's lots of nurturing activities, so tactile, skin to skin contact, eye contact. We'll offer nurture in positive ways, introduce it slowly, so we might do touch with a feather, maybe feather face painting.
One of the main purposes of Theraplay is for them to achieve, so we always want them to do really well. And we adapt the games depending on the age and the abilities of the children. When I go out and visit foster parents and explain what therapeutic parenting is, it's as if a light bulb just turns on in the head.
I think because we visit regularly, we go back and get the chance to go over what we talked about last week and see if they've tried it out and if it worked, and like you said, that you've had that light bulb, oh, I tried what you said and you know what, it worked.
I'm Gemma and this is my husband Paul, and we're both foster carers. I think initially we were a little bit anxious ourselves about going to panel. It sounded quite scary, but it wasn't at all. It was just a really friendly chit chat with a group of people around a table. It was more of a celebration really of us being there and of us, wanting to become foster carers. The County Council offer a fair rate of pay, so we get paid dependent on our level of experience. So after you've done it for a while, then your level of pay will go up based on your experience and level of training that you've done. We've also got a network hub, which is a foster carer support group, and it's just an informal get-together. We feel so valued as a foster carer for Nottinghamshire County Council. Everyone's so caring and wants what's best for you as a family. The matching process is really careful, so they listen to our needs and, they would never think of placing a child that wouldn't fit in our environment. As a foster family, we try and just make it everyday, normal life, try and bring some stability and love to that child that's staying with us and give them experiences that perhaps they've not experienced before. We love going out on day trips together, and for example today we've come pony trekking. Nottinghamshire's a great place to foster because we've got so much on our doorstep, there's so much that we can do. I feel really lucky that we're able to foster here.
I'm Leon, I'm a care leaver. I went into care when I was 8 for reasons of basically not being looked after properly. So I've been in care for 15 years, long time.
Lovely, thank you. I would like to welcome you all to this meeting of the committee, which has been held remotely, broadcast live and recorded for publication. The majority of the 11 members joining the meeting from their own homes. As well as myself, the other members present in the meeting today are Councillor Martin Wright, who is the Vice Chairman, Councillor John Doddy, Councillor Kevin Greaves, Councillor David Martin, Councillor Liz Plant, Councillor Kevin Rostance, Councillor Stuart Wallace, Councillor Muriel Wise, Councillor Yvonne Woodhead, and Councillor Richard Butler. We are in the process of waiting for Health Watch Nottingham and Nottinghamshire to join us, and once she's on, we'll see a name come up, basically. We'll be joined today by Hazel Buchanan and Lewis Satoria of Nottingham and Nottinghamshire CCG, and Ajanta Biswas from Health Watch to inform our discussion on the main items of the business today. We also have the following officers present today: Martin Gately, Health Scrutiny Lead, Noel Menemin, I'll get that right one of these days, Clerk to the committee. This additional virtual meeting of the Health Scrutiny Committee is being held in live with new requirements of in line with new coronavirus requirements, Act 2020. Please do bear with us if we experience any technical issues. If we do lose any member from the call temporarily, then officers will seek to assist in getting them reconnected as soon as possible, hopefully without the need to halt proceedings. Officers will inform the meeting if they are unable to rectify the problem and if we need the meeting to be paused or adjourned temporarily. During discussions, I would ask that members refer to agenda pack pages when referring to points within the committee papers. So item 1, apologies for absence.
No apologies received, Councillor.
Item 2, declaration of interest. Do any members or officers present have any disclosable pecuniary interest to declare? Do any members or officers present have any private interest, pecuniary or non-pecuniary, to declare? That's all a big no then, thank you. Okay, item 3, NHS National Rehabilitation Centre consultation response. The committee has been closely involved with the development of the rehabilitation centre and is meeting specifically today to consider the findings of the final consultation exercise and to inform the CCG's next steps. I welcome Hazel Buchanan and Lewis Satoria to today's meeting to provide us with the latest position. Over to you.
Thank you, Councillor Girling. So we've closed an 8-week consultation. So we've had previous conversation with the committee about this. Consultation closed on the 18th of September, originally planned for 6 weeks, but extended to 8 weeks to take account of the fact the consultation was delivered during COVID restrictions, so with no face-to-face contact. You'll recall that the consultation is a one-option consultation or an opportunity consultation. So there was opportunity to use national funding to create an NHS rehabilitation centre. That funding can't be used for anything else, so it was a one-option consultation. Consultation activity, we had a survey, a set of focus groups and some virtual events. We also commissioned Health Watch to undertake some targeted engagement with some groups and communities that don't traditionally respond to this type of exercise. So 2 reports the committee have got today are the core consultation report, which is North of England Commissioning Support Unit, and the Health Watch report. And I'll just do a really quick summary of both before handing over to Hazel, who can talk through the next steps for considering the findings. So in terms of the core consultation, we had just shy of 900 responses, 876 survey responses. A third of those were out of Nottinghamshire, two-thirds within Nottinghamshire. So we did promote the consultation to surrounding areas in recognition that patients outside of the county will be eligible for the centre if it's approved. A fifth, so 19% of the respondents were either current or former rehab patients, or they were carers of current or former rehab patients. Most people, 70% or 69%, answered as a member of the public and not as a professional. I'd say the headlines are most people are in support of the proposal, so nearly 90% of people responded, 86% exactly, support the proposal. The main change that the proposal represents, which would be the transfer of Linden Lodge to the rehab centre, is supported by 67%. Some of the concerns that people raised, mainly remoteness of the facility, potential issues with accessibility. There are mitigations in the business case and summarised in the consultation plan on transport, travel, accessibility, but these concerns still came through in the consultation. Some of the main benefits that people have drawn out in the comments, in events and in focus groups, tend to be around opportunity to improve the clinical outcomes, sharing of expertise between the NHS and military, and the quality of the facilities. Also coming through, a lot of support for the clinical care and mental health support. Although we've got a majority of respondents of the public, 67%, who support the closure of Linden Lodge and transfer over to the rehab centre, through some of the comments in the survey, some of the direct responses we've had to the consultation and the discussion in the focus groups, some people are concerned about the closure of Linden Lodge. We had some alternative proposals come through, so a handful of people asking if we can invest in the existing Linden Lodge facilities and build the rehab centre, which wasn't part of the consultation. We also had some concerns raised by some national clinical bodies, which echoed some of the concerns in the wider consultation about remoteness of the facility, being separate to urgent care services and accessibility. So that's the broad brush summary of the main consultation report. I won't dig right into the detail because it's quite a long report that you would have had sight of. The Health Watch report was a slightly different piece of work. So this was intended to be more detailed and more targeted. So we intended to use this to reach out to some more diverse groups, and that's reflected in the responses. So a fifth of people who responded to this exercise have a physical disability, 1 in 10 have a learning disability, nearly 1 in 5 have an existing mental health condition, and 20% of people who responded to that work from a Black or Asian minority community. A third of respondents to the Health Watch work are also either current or former rehab patients or carers of rehab patients. The same proportion supported the proposal, so 86% in support. In terms of some of the detail, I won't go into it too much because it is, again, a long and detailed report. As it was a more targeted piece of work, we did get a different type of feedback. So we had some interesting points raised around people's personal preferences for privacy, concerns about who arranges childcare for inpatients, and then some quite specific points. Most of the conclusions that Health Watch have made in their reports are around needs being addressed on an individual basis. So things like privacy being considered on an individual basis, as things like sex, religion and culture all create different needs. One of the interesting findings from that piece of work is something that didn't come up in the core consultation, but people with pre-existing mental health conditions flagging that they want reassurance that their existing condition will be cared for while they're in the facility. So there's a lot of feedback around mental health support in the main consultation, but that tended to be concerned that a mental health issue that arises because of rehabilitation need will be seen to, rather than a pre-existing mental health condition. So overall summary, the proposal is well supported. Both exercises have highlighted that. There are some concerns around location and accessibility, and I'm sure in the questions we can get into some of your observations around the two reports. I'll hand over to Hazel, who's managing the process for taking the findings of the consultation and translating those into recommendations.
Hi, thanks, Lewis. So just quickly, the process now is that we consider, as Lewis said, both reports and how they impact or influence the decision-making business case. So we will take all elements of the feedback and the recommendations from the Health Watch report and consider those in turn. And they're as Lewis said, there's different levels of feedback. So some of it's from professional bodies, as an example, around the proposal to have 3 beds remaining at NUH, and then there's others very specific to patient needs and in relation to the environment. But each of those will be considered in turn, and this will be reflected in the decision-making business case. We have what we've called a findings consideration panel. Lewis will be able to talk a bit more about that. But we mentioned that before as part of the process, and they'll be looking at, or we've started the discussions as to how do we actually take the reports and make sure that we are considering the points in enough detail. The decision-making business case goes to our governing body for approval. So I think before when we spoke to you, we talked about quite a detailed assurance process that we had for the pre-consultation business case. We don't have the same assurance process with NHS England for the decision-making business case. So this will go to our governing body for approval in December, and we'll have oversight from the NHS England. So they'll have sight of it, but not take it through an assurance process. Just to mention that we will be having a detailed discussion also in governing body closed session in November, and that's to flesh out some of the questions and outstanding points they had, how those have been addressed alongside addressing the points in the consultation, and that then will help to inform the final decision-making case, as I mentioned, for December. So leave it at that, and welcome your comments on the engagement consultation.
Sorry, Councillor Girling, I think we're struggling to hear you.
Can you hear me now?
Yes.
Right, it was the headpiece. It's what I was off. It says I'm not muted there. Sorry about that. I've got Muriel first, then, please.
Oh yeah, and many thanks both for such a thorough piece of work. And I think it's very. I found it really interesting that I thought the consultation would perhaps not be exactly thin, but might be difficult to get a range of views during the COVID period. But clearly, you've done a really good job at getting people's views. I suppose my questions are a bit predictable in a way, but I'd just like to hear a bit more about them. In paragraph 6, 1 to 3, the comments made by Derby Hospitals, they raised the issue about staff resources for managing split sites, and will that be both expensive and challenging? And then also the resource issue, which I think obviously is around substantially, but particularly that the bottom point on page 55 about the significant number of patients who would normally be in a level 2B inpatient unit will be ineligible for the rehab centre, and then there'll only be the resource of the 3 acute beds in Nottingham City. I thought the criteria for the rehab was going to be a bit more flexible than that, but perhaps I misunderstood. So it's an issue about, the split sites and staff resources, the capacity issue for patients, particularly those at level 2B inpatient need. Thank you.
Thank you, Muriel. Do you want to take that?
Yeah, so it's since the pre-consultation business case, and whilst the consultation was going on, NUH have done some more work on the workforce plan, and so we will have the resource from Linden Lodge transferring over. There will be other resource because we're reducing the activity in the trust that potentially could transfer over. And then it's also then how do we start a recruitment drive and upskill. So for some of the roles, there is a requirement to upskill, and that's been considered as part of the education proposal and is included in the workforce plan. So there's one role in particular where if they are to have those in place for when the centre is to open, they need to get them through the education programs next year. So there's current work going on with the universities as to how to expand the education programs and what's the opportunities with that. So there's quite a bit happening around the resource. It was something that we were challenged on through the clinical Senate panels that we've got that we have in the NHS, and we've just taken it through the case there. They were raising that they want to make sure that the centre wasn't going to be also taking all the resource, valuable therapist resource from existing units, and then that going to the rehab centre. And so we actually have a lack of resource in other areas. So that has been taken into consideration in the workforce plan, but is something obviously that will have to be monitored and managed as we progress. So I think since the pre-consultation business case, there's been quite a bit more on the workforce plan, and the clinical Senate panel felt comfortable about the resource and the levels of resource that are in there, and the proposals around the education, but acknowledge that there will be some challenges, and it's just how we manage that within the whole context. In relation to the 2B patients, so we've had some further conversations, and in particular since we've had the feedback through the consultation around the 3 beds remaining at NUH, and we're now considering whether there's the opportunity to transfer 24 of the beds instead of 21 of the beds. And as part of this, what we do need to look at is what is the gap, and this tends to be for patients that have slow rehab, longer term needs, and more acute needs. So it's what do we as opposed to commissioning it as 2B, it's what are these patient needs, and they're different to what Linden Lodge potentially should be providing, and what we'd be providing at the major at the NHS rehab centre. So there'll be some developments around that as part of the decision making business case, but the thought is that there maybe could take patients slightly more complex than they originally thought, but there is some more discussions to be had around that.
Would you like to come back, Muriel? You're muted. You're muted, Muriel.
Yeah, thank you. Thanks for that, Hazel. Can you just give me an example of where that kind of criteria might become quite complex in deciding who goes to the rehab centre and who doesn't, in respect of what in the past has been level 2B?
Yeah, so the criteria is there's almost 2 elements, or I say 2 elements to the rehab centre, which will be the 2B unit, which is Linden Lodge, and transferring that, and that's complex patients. And then there's the major trauma patients, the MSK, and some of those would be neuro, less complex than the potentially what we've called the 2B patients. So those, they'll they'll be assessed by the referral criteria, and the referral criteria are in effect the same as what was in the pre-consultation business case. But what's being built around it now is is more detail around the referral form and the trusted assessor model. And they've also built into the process a red, amber, green level. So the red, amber, green would be evaluating whether the person is needs would be fully met by the rehab centre and by their rehab potential, or whether their needs are not necessarily fully met. And that will be what will happen is there'll be the referral form, and the trusted assessor will assess the patient. Then they'll go through a multidisciplinary team review, and there'll be a detailed discussion as to whether that patient is fit for the rehab centre, whether there's capacity at the rehab centre, and if not, where do they go? And that's quite different to now, where it's assessment will be carried out by Linden Lodge, let's say, and Linden Lodge are making that decision, but then there isn't that follow through as to where the patient may go if they're not fit for Linden Lodge, and so that's built into the process. So I think again there's quite a bit more around that's making it more robust, and so we'll be able to reflect that in the decision making business case.
Okay, thank you.
Are you happy, Muriel?
I still have a concern. I suppose it's just a bit theoretical at the moment, isn't it, about who might fall out. We're given that eligibility criteria and obviously a good multidisciplinary assessment. Who are you concerned might fall out of this, and we might struggle to find resources for them?
Yeah.
What sort of level of need might fall out of this?
And I think so there is the risk that there's quite a bit of level of need that falls out of it. And what the clinical senate actually made a helpful recommendation that we carry out an audit soon after this goes live. So their view is that we've got to monitor it closely, because it's in effect the major trauma element is something different what we have now, and so we've got to closely monitor what's happening with the patients and where they are going, and carry out an audit. So they have suggested that they would be able to do that audit as almost an independent body. And so we've really welcomed that opportunity, and that's them recognizing as professionals it's going to be a bit of a learning experience at first, and we've got to make sure that the patients are getting the right care in the right place.
Yeah, that's very encouraging, and that audit sounds a really good idea. Thank you very much.
Yeah.
Thanks, Muriel. Great questions. John Doddy, please.
Thank you, Keith. I think when this was first brought around, there was a great enthusiasm for a national rehabilitation centre, and certainly the thought that it would put us front and foremost as the envy of the East Midlands nationally and perhaps even internationally. And I think it was a pretty comprehensive piece of work in terms of the consultation. There was a large amount of that goodwill feeling that still seemed to permeate through about the National Rehabilitation Centre, but it was equally well balanced by a sense of something lost. And I think that the general feeling you get is that this is not a like for like service. This is not swapping one unit for an identical unit, which is a little bit like the point that Councillor Wise was making, that there's something very positive about it, but the report itself doesn't mirror that is what's been given up by Linden Lodge, and it's that gap that's important. If you look at the specific concerns, particularly say page 5, and it talks particularly about acute medical and surgical services, that the medical instability and complexity of people receiving care in Linden Lodge, it felt was not going to be replicated and managed in the same way at the NHS Rehabilitation Centre, due to their inability to engage, etc. This is not a one-stop shop. The one-stop shop is Linden Lodge and its embeddedment within an NHS facility. And I think that's a little bit of the points that have come out so far. The one-stop shop element of having it all on one site and being able to deliver it. Again, positivity in large part, but it's a bit surprising that the British Society of Rehabilitation of Medicine again raised concerns about the high proportion of patients on page 52 at Linden Lodge who are currently receiving high levels of care that might not be replicated if they get to the National Rehabilitation Centre. The Derby CCG, Hazel, I note that you're here representing Nottinghamshire. It might be nice to have somebody from Derbyshire, because the Derbyshire, it says here, were neutral. I would have said neutral was sort of putting a nice tint to it, that they had concerns about location again and access to service. The University Hospital, as mentioned by Muriel Weiss, again had concerns with regards to the same things. In a way, I suppose, there are attractions to Linden Lodge and the National Rehabilitation Centre, and the impression I'm getting is it's a little bit like being on a farm and you sell your combine harvester and you buy a milking machine, but do you have any cows, and how are you going to get the crops in? So there is something to be said for both of them. And my impression is that the public are saying to us, we need both, Hazel. The public are saying that we can't get rid of one and rely entirely on the service being provided by the National Rehabilitation Centre, brilliant as it may be. I'm particularly interested in the crossover period of time. If we close Linden Lodge and we open the National Rehabilitation Centre, are they a simultaneous process, or is there a degree of overlap? I think that you said that we need to do an audit after the National Rehabilitation Centre opens. I think the public would probably like to see a long period of overlap between the two facilities, possibly for as long as 12 months. In other words, that we're not auditing failure, we're actually monitoring success. And that's what comes loud and clear to me through this. It's a very positive thing, but it is not a like for like swap. And as I say, that period of audit should be a period of significant overlap in order that, as I say, we're not looking at our mistakes, we're monitoring our successes. And that's what's come through to me loud and clear, Lewis and Hazel. Thank you.
Who's answering that one?
The farmer.
So, yeah, it is difficult, but we have to work through more for the decision-making business case is that the program team are extremely confident that it is the same cohort of patients that would be transferring from Linden Lodge, and now feel that it can be a more complex cohort of patients. As an example, at the moment, tracheostomy patients can't be treated at Linden Lodge, but they can be at the NHS rehab centre. So we do have to work through that and demonstrate that more in the decision-making business case. We don't, unfortunately, have the funding that would allow us to have an overlap of 12 months, and in the consultation there is obviously the feedback there that Linden Lodge should remain, but that's not an option, and thought that was clear in the pre-consultation business case. We do have to transfer Linden Lodge, but we're absolutely committed that same cohort of patients for Nottingham and Nottinghamshire will have the same access to services. But we do have to express that more convincingly, shall we say, in the decision-making business case.
I'd just add to that, Hazel, as well. There's something in this actual structure of the exercise that was quite tricky to put across, which is why the closure of Linden Lodge was one of the key questions in the questionnaire. It's an opportunity consultation. So, do you want us to invest in this service, knowing that this is the impact on the local service? So it was a difficult one. And if there's one criticism of the exercise, then maybe we could have tried to make that much clearer, because we did get some feedback asking for investment in Linden Lodge and the NHS Rehab Centre, and the consultation was framed as you can have this, but the impact would be that we can't run both services.
You happy with that, John? Do you want to come back?
No, only I hope when we do review it in a period of time that we're all happily reassured that it has all gone well, and it'll perhaps only be in hindsight that we'll be able to actually know whether or not that it was like for like, etc. But I don't think that any downfall will be due to lack of diligence and hard work on behalf of the people who are overseeing it, who I have every confidence in. Thank you.
Thank you, John. I've got Councillor Woodhead.
Chair, my question's been answered. Thank you.
Okay, thank you. That's Kevin Greaves next then, please.
Thank you, Chair, and thank you both for coming along today, Hazel and Lewis. Yeah, I mean, we've got to get this right at £1,175,000 per bed. It's got to be right. And looking through all the papers, you see that many times there's the remoteness of the establishment come up. And I'd like to know what strategies NHS rehabilitation centres are going to use to recruit staff, bearing in mind the shortage of specialist medical staff at the moment. I mean, with it being so remote, I mean, they look like having to have obviously their own transport, because if they haven't, they can't even be considered for a job there. So unless one of the incentives is a free car, I don't know. So how are you going to address that, please?
Yeah, so there's a few things in relation to that. So one is, it's expected that there will be a draw to the centre, with it also having the research and education element, but also being a new state-of-the-art facility and an opportunity also to be involved in a new cohort of patients that are receiving a different type of rehabilitation. And there's also the opportunity to work closely with the military and the learnings that provides. So it's expected that there'll be a certain level of draw. But so mentioned, the Clinical Senate did highlight also that there will be challenges in resource. So it's what practical elements can be considered, such as transportation from the city centre, let's say, to the rehab centre, or is there, something that could be done through Medilink that's specifically in relation to staff shifts? So there's some very practical things. There's discussions with the military side about how we can manage recruitment jointly, and so that's not staff that are both working in both facilities, I should say, but it's how do we learn from what's happened in the military and recruitment, and is there any opportunities to do recruitment drives, etc., jointly. And and it's the link to the university. So if we're getting people through programs specifically in relation to the rehab that will be provided at the rehab centre, then in effect we're training up that resource for the rehab centre, and there will be considerable work that has started now around the recruitment and around the workforce, but everyone acknowledges that it'll be challenges, just because also there's just challenges everywhere, as we know, in relation to recruiting clinicians. So absolutely, it's acknowledged it's a challenging area. There are practical elements that can be done, and this will be considered as part of the ongoing work in relation to the centre. So it will go beyond the decision-making business case.
Do you want to come back, Kevin?
Thank you. That'll do.
Lovely, thank you. Stuart Wallace, please.
Thank you, Hazel. Can you hear me? Yeah, okay. Right. It's a good paper. It's well researched. What I find somewhat problematic, and John's already gone through it when he was talking about Derby Hospital have severe considerations. Derby CCG, equally they have them. British NHS Leicester oppose certain sections. British Society of Rehabilitation have concerns. College of Physicians also have concerns. And when I read comments that tell me, for example, Rehabilitation Medicine Specialist Advisory Committee, paragraph 2, a basic misunderstanding of the need of rehabilitation and the remoteness of the location, etc. And it then goes on to talk about its location. So that does worry me when the professionals are saying we have concerns. And having been in things where we build things from the start and building upwards, quite often you build it on a concept, a dream, on the hopes that it actually will deliver. What I would like to see in any report where the issues of all these professional medical bodies have had their concerns put to bed, or if they haven't had them put to bed, you've had a risk assessment on how that will play out, because once it's built and once it's had its 1.x million pounds per bed invested into it, I do suspect there will not be any more money coming for a number of years. So if we get it slightly wrong, we're going to live with it wrong for quite a long time. And my other one is that I haven't seen anywhere here where where the assessors went out to hospitals, to where the people are that we want to recruit, and test whether people want to come in, want to travel over to here, want to be part of this sort of thing. Not offer them a job, but say the job would be this, and salaries would be that, and travel would be this, and this. Because you're coming up with, for me, having tested something and having a very good answer to the questions that have been raised. Thank you.
Lewis, do you want to pick up the one around consulting?
Yeah, so we did have Linden Lodge staff at focus groups and at some of the events. We had a range of healthcare professionals and clinicians at the events as well. I can get the facilitators to pull the attendee lists, because I think you'll see there was quite a wide range of different professions in there. We also had a good chunk of people who were responding as a healthcare professional rather than as a member of the public. But I think you're right in that some of those responses are lost among the 876. We did have some pre-consultation engagement as well. So we did do some engagement before the consultation, and that included some exercises with Linden Lodge staff, and NUH ran regular briefing sessions with Linden Lodge staff as well. But we can get some more information on who from the different healthcare professionals has contributed, if that would help.
Well, the thing I was saying, I mean, if you're in engineering and you want to set an engineering base, you'll be able to go because you'll have gone out and you'll send headhunters out there to actually test the waters for you. And you will know that you would get that number of people coming to whatever your area is you live. Like in Oxford, that's where the Formula One are, for example, we're prepared to move house, children, everybody over there in order to be able to get into it. You've tested it. People didn't have to do it, but you've tested people who would show interest on it. And that's the bit. I mean, a lot of people have come and had a look at it. How many people said, yes, I could work here. I would like to work here. Once you're ready and up and running, it's that test. You've got sort of a basic guarantee you can actually staff this thing.
Yeah, I suppose we're straying into the realms of off the scope of the consultation. So it's a formal public consultation. So we have had staff taking part, but we're quite clear it's an exercise to test the views of the public. As part of that, you inevitably get the views of staff and clinicians and various healthcare workers. But the feasibility of the workforce model is part of the wider business case, whereas the purpose of the consultation specifically is to test the views of the public.
Okay.
Yeah,
So I think just to mention along in relation to existing staff, so the Linden Lodge staff have been out to the site a few times, and it's with that view of, you know, can you work here? Predominantly people can, but there's obviously some people who can't, which they're working with them at the moment as to what would be, you know, where would they work if they didn't transfer and they were still employed by Linden Lodge. But then also if there's any recruitment going on at the moment, then part of that discussion with the person and part of the recruitment process is detailing that there will be a NHS rehab centre and how do they feel about that, and talking about the location. So they are trying to get more of that understanding, and that will be ongoing. And I think just to your first question, so the points raised, we absolutely have to address those in the decision-making business case, and either outline how we've changed the case as a result, or if we haven't changed the case, then why not? And as you say, potentially there's a risk assessment or consideration as to how we evaluate that element as part of the implementation and as part of the development of the capital cases as well.
Okay, thank you.
Thanks, Stuart. Councillor Martin, please.
Yeah, thank you, Chair. Good afternoon, everybody. Yeah, I mean, first and foremost, I think we should remind ourselves that we are getting an absolutely wonderful state-of-the-art facility, and it is centrally located. It's a national rehabilitation centre. So the objective problems about getting to it will have to be addressed somehow, and I think if we don't go forward with this venture, with the amount of money, the colossal amount of money that's being invested in it, it sounds, from some of the responses, it sounds to me like back in the late 90s when everybody said don't use a mobile phone. Look where we are today. You know, I mean, I can agree with some of them, so some points that want addressing. So I'll take you to your own conclusions, page 69 of 130, where some of the responses are on there. So the isolation of patients and their inability to get out of the centre to any of their family, and equally the difficulty for families being able to get to them. The other is the options for those who are ineligible for treatment there with ongoing long-term life degenerative illnesses like MS. You know, what are going to be the options for them if we close Linden Lodge completely? Lewis, earlier you mentioned that there were other options for Linden Lodge that you might be bringing forward, so I'd like you to expand on that a bit. And can you answer the practicality of having 3 family units at the lodge? And my ultimate question would be, because it's a fantastic piece of work, so my ultimate question to you two would be, do you believe that the consultation process has benefited and evolved the process and the end result of the facility that we're going to receive in the end?
Shall I start, and then Lewis, you could. So on the long-term conditions and Linden Lodge, so those patients that we're able to access through Linden Lodge will still be able to access through the rehab centre. So it is expected that they will still be treated at the rehab centre. On the families, absolutely, and we'll explore that further over the next couple of months. There's a commitment to making that work, but there's obviously a limit of options. And again, I think it's something that will develop as the unit opens. But they have put in the so there's been more work on the architect drawings, and as part of that, they're now considering 4 family not apartments, but 4 family units, and also 2 of the rehab flats. So we had, when we presented to you before, there was 1 rehab flat, and that's where the rehab flats are, where is part of their, obviously, is their rehab, but they'll be staying there with family members, or it's replicating what their circumstances will be outside of the centre. So there has been further consideration in that, and recognise the need to increase those facilities. The options for Linden Lodge, I'm not sure what you're referring to. I don't know if, Lewis, you've got... Can you just expand, Councillor Martin, on, you were saying that Lewis mentioned about some other options for Linden Lodge?
Yeah, I thought I heard you say earlier that you were exploring some other options for its use after it's closed. Is that not? Did I hear that wrong?
No, I think the reference to option was, we had quite a few people propose that we explore an alternative option, which is to invest in Linden Lodge and the rehab centre, which wasn't on the table, but there was a fair chunk of people asking for that.
Yeah.
What we do know is that the Linden Lodge, the facilities themselves, that building is not fit for purpose. So the expectation is that if it's still there and it's not knocked down, and we've got tomorrow's NUH happening now, but if that's still there, it won't be used for a clinical purpose. It would be more for offices or something, as opposed to clinical, because it's getting to the point where it's no longer fit for purpose. And then the other question was, has the consultation benefit involved? I think absolutely it will. It's been, it's mentioned before that we're really pleased with the level of input that we've had, and the robustness of the feedback, and the fact that we were able to do this in a virtual environment, and I think the analysis that has been done, and equally the work that Healthwatch have done, means that we can directly apply this to the discussions around the decision-making business case, and opportunities going forward. I don't know if you, Lewis, if you want to.
Yeah,
add your thoughts to that.
I'd echo those points. So, I mean, the purpose of the consultation is to test our proposals with the public. I think we've effectively done that. We want to produce meaningful insights that are actionable. We've done that. So now the bit of the process that we're in will be taking that feedback on board and trying to feed it in. And the way the consultation has been carried out has enabled that to happen. And I'd 100% echo Hazel's point about the virtual consultation. So it's a big challenge. There are other areas that had live consultations that had to switch to virtual, kind of March, April time, but this was the only one I know of that launched in that period. Had some challenge at the start as to whether we could still make it a meaningful consultation. I think we've shown you can do it virtually. You just have to put a bit more work in and be a bit creative with your method. So it's been a good exercise for us.
Yeah, you're talking to somebody from a council who never stopped. We went on to Zoom on the 25th of March. The only question that wasn't answered is what options, with your NHS Nottinghamshire hat on, Hazel, what options will be available when Linden Lodge closes for people with lifetime debilitating illnesses like MS?
Yeah, so at the moment it's written very much this referral through through a trust, and Linden Lodge see patients. Are you saying the patients that have long-term conditions that maybe come into Linden Lodge either as a day case or a top-up after that, you know, from home? So it's not after a stay in a hospital stay, and that's something that we're considering or looking into and reflecting that more in the decision-making business case. I think there's still uh, uh, there's still a outstanding question, and it is absolutely an outstanding question around day case and how can we accommodate day case. On the flip side of that, and I think that's in there is a comment in the consultation, is that then if you're looking at day case, there's the challenge of travel, but it's how do we, as you say, how do we ensure that we are providing the service, one that we currently provide through Linden Lodge, but are meeting the needs of those patients with the long-term conditions. So I think that, well, that is something that we need to explore further for the decision-making business case, and just provide greater clarity on that.
Yeah, thank you very much for your answers, and I'm sure it'll be a great success. Thank you.
Okay, Martin Wright, please.
Thank you, Chairman. Yes, my questions, or a couple of questions, revolve around the consultation itself. Councillor Wallace has already said that there are misgivings from some of the professional bodies, stakeholders, etc. But my main interest is in the number of people who responded to the public survey. And from page 27 of the report, there were 714 responses from East Midlands people. I'd like to ask, first question is, Health Watch surveyed 91. Is that 91 part of the 714, or are they extra? And the second question, do you think 714 is a good sample of Nottinghamshire's or the East Midlands population? And on page 17 and 18, there's a list of media coverage. I look at that and I see there's no real media coverage to the north of Nottinghamshire whatsoever. And that's reflected on page 27 of the number of responses. Mansfield 10, Ashfield 16, and there's no mention of workshop whatsoever. Again, looking at the media coverage, Yorkshire Television is very effective in the north of Nottinghamshire. Nothing was sent to the Yorkshire area. Everything was addressed to the East Midlands TV, East Midlands newspapers, such as that. So we can't expect a great response from the north of Nottinghamshire if north of Nottinghamshire don't know anything about it. And I'm the councillor from North Nottinghamshire, and I did know about it, but I didn't see it in the media locally. Thank you.
Shall I take those ones, Hazel? Yeah. So yeah, on the Health Watch numbers, there's 91 are in addition to the 800 or 700 odd survey respondents. So they are additional. So I thought we had something in the chat, so I will check that. Maybe not. We did put a lot of resource into Facebook advertising in the surrounding areas, but some of this was a question of what went out in the weeks we were doing the promotion. I haven't gone into detail to subdivide the sample down to look at the various boroughs around, so I can't comment on that in this meeting. In terms of whether it's a fair sample size, I mean, it's not a piece of academic research, so we're not looking for a representative sample. What we're looking to do is to give the people in the area as much opportunity to respond as possible and to put as much effort in to advertising the consultation. So 700, 800 is a really good number. The patient population affected is, I think, around 150. Hazel will correct me if I'm wrong, but there's a relatively small number of people eligible for specialised rehabilitation. So to get this many people, 700, 800 people, a good chunk of whom are current or former rehab patients, we're quite happy with.
Do you want to come back, Martin? Do you want to come back? Okay, thanks to everybody. Do any members who haven't spoken want to say anything? Okay, I'll just put their hand up. Well, Liz.
Thank you, Chair. Can you hear me? Yeah?
Yeah, absolutely.
Right, yeah. Yes, some of my questions obviously have been answered, but certainly we had two very thorough reports, despite the difficulties, obviously, that the COVID threw up in terms of doing the consultations. I mean, I don't pretend, obviously, to have any medical knowledge of the severity of the conditions that would actually require such specialised rehab. But I am sort of making an assumption that some patients will also have other medical conditions as well as the need for this rehab. So I'm just wondering how support for those other conditions, when they're in this the NHS rehab centre, will be met. And obviously, will they have to be taken off site for that and then be brought back? I don't know. So I'm just sort of curious about how that works. The other is a question about, again, have no knowledge, sort of, and I know this will be obviously dependent upon the individual patient, how sort of long, what are we talking about in terms of a patient might be expected to be in the facility? I might be asking a question that you can't answer, I don't know. And that also, again, plays out in terms of the fact that that's also been mentioned, obviously 3 family rooms for a possible cohort of 63 patients. So just if you could answer some of those questions, that would be helpful. Thank you.
So on the staffing, they are considering it. So there's considerable medical cover, so consultants and junior doctors, but they're also considering how they can get the cover from other specialties that are required and rotate that through. So bringing the resource out, there'll be there obviously is what can be managed virtually. So that will be taken into consideration, and as part of the workforce plan. I mean, obviously they can't cover, depending on what other conditions people might have or what comorbidities, but they are working through what. Because for the neural rehab, they're able to look at the Linden Lodge and we're going to do a codependency analysis. So take all the specialties that Linden Lodge patients currently access and how will they access that when they're at the rehab centre, and break that down in detail. But the view is currently is that they will be able to cover the different needs, and where they can't, it will be how they link in with the trust, obviously considering patient safety as well. So I think that's quite a broad question to answer specifically, but it is something that has been taken into consideration in the fact that it is the remote site. In relation to how long they're expected to be in the facility, so the major trauma patients, which is the MSK, complex fractures, and some neuro patients are expected to be having a 2-week stay, and the current Linden Lodge average length of stay is 70 days, and so that's what's been factored in. The majority of patients will be the 2-week stay. Well, I think I mentioned that there's going to be 4 family rooms, accepting that one more family room isn't significant when you're looking at the number of beds at the rehab centre, but also recognising that a number of families won't be interested in staying actually in the rehab centre. So I think we have built in one extra room, and as mentioned, 2 rehab flats to help accommodate the needs of visitors, but they'll be and this will have to be managed alongside the other options to support families in visiting. Does that answer the questions that you had, Councillor Plant?
Yes and no. I think the first question in terms of other medical conditions that they have, perhaps not answered as fully as it could be, certainly. But we'll leave it at that now, I think. Thank you.
Thanks, Liz. Has any other member that's not spoken like to speak? Oh, Councillor Rostance.
Hi, Hazel. You mentioned the day services, Hazel. Having personal experience in this, my wife was a patient at Linden Lodge, and they were brilliant. But the care she received went on for a further 2 years, and from what I can gather, there are quite long-term day services provided by Linden Lodge. Have we got any details of just how that does affect a majority of people?
So the in the pre-consultation business case, the outpatient side and some of the day cases staying at NUH, and it's just whether we can also build in day case options at the rehab centre. So the outpatient bit, the view is that that would stay at NUH, and equally if a patient's from Lincoln, Leicester or Derby, they'll work with them to manage the outpatient side. So it's and there are the resources there to do that.
So people won't commute to the new centre. It would be if there are better based areas nearby.
Yeah.
Thank
yeah,
you.
and it's just whether there's additional opportunity to include day case at the rehab centre, but that's got to be explored further.
Thank you, Hazel.
Okay, thank you very much, everybody. I take it everybody's had a say who wants to have a say. I think it's a great paper to come before us, and as Councillor Doddy said at the beginning, if you look at it with love in your eyes, it's a great thing. How can you talk against it? However, during the meeting, we've had councillors giving concern about some of the continuation of services, and also from some of the big hitters in terms of partners have said so as well. And I just want to sort of, and this is no reflection on our concerns about you delivering these services at the new facility, but I think Councillor Doddy brought up at the beginning about keeping the lodge open as a continuation to make sure that nobody falls between the gaps, and that we're measuring success, not then concerning ourselves with any failures that it might have. So I'm looking to the committee for approval, really, to maybe put in a recommendation that Linden Lodge is kept open as an overlap and maintained to ensure that there is a continuation of service for, I would say, a minimum of 6 months, but hopefully for 12 months. And I know you've said, Hazel, that you can't afford to do that, but our concern is our residents, yeah, and that they continue to get the service that we believe they deserve. So can you sort of indicate to me, the committee, if you're against that kind of a motion, or if you want to say anything on that, because that's what I'd like to propose. Does anybody like to speak? I've got Kevin. Is your hand up still from before? Yeah. So I've got John Doddy then, please, and Muriel Wise.
Yes, I think Councillor Girling, the opening sentences hinted around the idea that we were not necessarily replacing like we'd like. and much as though there is a certain similarity, they're not identical twins. They might still be twins, but there's a good bit of difference between them. I think that in order to measure success, as you quite rightly pointed out, then we have to have a balance of protection against failure. And I think the overlap for 6 to 12 months would certainly give us the reassurance going forward that even such points as the follow-up that Councillor Rostons mentioned and the other areas are all being maintained. There's no point in bolting the stables after the horses fled. So I think it's an excellent idea and has my full support, Councillor Girling.
Okay, thank you for that, John. What about Muriel?
Yes, I think it's a really sensible recommendation, Chair, particularly because all new building and new projects often have a slippage of time on them, don't they? So that to have the safety net of Linden Lodge running parallel in an ideal world would be really positive. I think my main comment, and obviously Hazel and Lewis will be looking at this, but my concern would be about the staffing of it. Spreading staff too thinly over both units might be impractical, but I certainly support us recommending that this be looked at really seriously as a possible solution. Thank you.
Okay, so I take it then nobody else has put their hand up, so we're all in favour of that. I just need a sort of a bit of indication. Are we looking? Because I did say 6 months, but hopefully 12. Are we happy with that then? Please say if you're not, because it's easier that way. Then everybody put their hand up, say they're in favour of it. So we go for 6 months, but and put in within the recommendation hopefully for 12. Yeah. Okay, so that's our recommendation going forward. So if you can take that back, Hazel and Lewis, to your board. I know they're not going to be particularly pleased with us, but we have genuine concerns about the continuation of service, and it's better to have those fears considered and actually proven wrong, that they'll be proven right, and then there's some people suffer unnecessarily because we're right. Yeah, so I really do need that to be taken seriously, our recommendation. Is that okay? Do you understand where we're coming from on that?
Yep, thanks. Yep,
okay.
That's fine.
That's everything for you. Sorry. Okay. Hello, Janta. Really sorry for for missing you out on this. Is there anything you would like to say to get your point across? Did you hear that last recommendation?
Thank you, Councillor. I came at the tail end. I'm really sorry. I've had terrible problems with BT OpenReach digging up, so I've finally joined in. I heard you at the tail end, but I don't know what the recommendation is. So if you don't mind repeating it really quickly, I'd really appreciate it.
Yeah, no problems at all. Because of the concerns being expressed by both the committee members and some of the consultees with regard to the service being continued and maintained, we've put a recommendation in that Linden Lodge is kept open as an overlap for a minimum of 12 months, so that we can make sure that nobody falls through the net and that a like-for-like service is being provided.
Thank you.
Yep. Would you like to add anything?
No, not on that recommendation. I'm happy with that. Thank you for letting me know, Councillor.
Yeah. Would you? Now we're coming to the end, to be fair. So is there any points you'd like to get across while we've still got everybody here?
I have said this to Lewis in a different meeting, but because everybody else have not been there, I'll repeat it here, that there has been now 2 consultation documents, and the point to raise is that the voices of individuals' lived-in experience in what the Health Watch consultation document raises, and the minority groups, is to perhaps not be lost during in the rest of the other consultation and the other recommendations. So that was the only point that I had raised, and Lewis is aware of that, which I'm assuming Lewis agreed with me in the last time I raised. So
Okay, thank you for that.
thank you.
That sort of brings us to a conclusion then. So I'm really sorry about that for you. We'll try and make sure that we're not digging up your broadband lines up next time we have a meeting. But thank you for making the effort and coming to speak to us. So that's it for you, Hazel and Lewis. Thank you very much for your contribution. I think it's been a good debate. I think you see the concerns that we've got as a committee in terms of the continuation and the like for like. So please take that back to your board as strongly as possible, in strong terms as possible, please, because we do feel very strongly about it. So thank you very much.
Yeah, will do.
Yeah.
Thanks very much for your
Well
time.
done.
Thank you.
Bye.
Okay, that takes us on then to the item 4, which is the work programme. To introduce the item following the cancellation of some meetings during the lockdown period, the work programme has had to be revised and rescheduled. I now invite Martin Gately to comment in more detail.
Thank you very much, Chairman. So I'll just give you the details of the next meeting. The next meeting is on the 10th of November. On the agenda will be tomorrow's NUH, COVID-19 and mental health, which is deferred from this meeting, an additional item on COVID, which is on COVID recovery, and at the request of the CCG, a briefing on the Chatsworth Rehab Ward. Now, previously on the agenda would have been dentistry and orthodontic provision, and that's been postponed now to the December meeting. Thank you very much, Chair.
Okay, thank you, Martin. So I've got Muriel, got your hand up, and then David Martin after that.
Oh, thank you, Chair. Actually, I'm reassured by what Martin has just said, because my concern was, I hope it's going to be covered by the next agenda, is that the repercussions of COVID are pretty substantial, and it's not just in relation to mental health. I've got quite a long list of situations that have been exacerbated by COVID, particularly the inconsistency across GP surgeries and accessibility, equally the same across dental services, and also the inconsistency across early childhood support. I mean, for example, I had a situation recently of a resident in my district where her baby was just at birth. It was planned that he should have a scan, and that scan didn't happen until he was 6 months old. So just 6 months of absolute anxiety by parents and so on. And from the group that she's in, I know that that wasn't an isolated situation. So I know that it's extremely challenging. I'm not out to blame people, but I think we don't want to be reviewing this next year when things are more established or more worrying. I think it's important for us to review these situations as soon as we can, and that officers make time to talk with us. So I would hope that the session in November there'd be time for us to look at the wider implications for COVID, and particularly how as councillors we can support NHS in giving people in our communities the right sort of information to go to the right places at the right time, to have confidence. I'm part of a patient in an extremely good practice. I've been seen during COVID and had really good treatment from them, but I know it's not the same for everybody. So, I think, and it's also being, as councillors, being explained to people where they could be confident to go forward with symptoms and know that they're going to be seen, and not hang back so that symptoms deteriorate and they're then in a crisis situation. So if that item could be as broad as possible, Keith.
Yeah,
with the CCG.
Absolutely, Mura. I'm, as you know, I try and push mental health as much as I possibly can, having been somebody that suffered from it, and I know how important support can be. I think we've got to get it to come to us at the right time. You know, in fact, only this week I think I've spoken to Neil Betterson, who's as Armed Forces champion, to see what mental health first aid courses we might be able to get funding for, because you know we need to make sure our staff are really well prepared for this, because there will be an upsurge in it. Also, as a counsellor, I found a great benefit of doing the course. So it's not just about learning and looking for signs from other people. By doing the course, you also notice signs for yourself. And so it's a double-edged sword for me. It actually helps the person that's on it for them, but also for looking for people that might need support. So absolutely, I did allow it to get bumped because I understood the reasons, and it's important that it comes to us at the right time, with the right amount of meat behind it. And I think doing it in November, we'll be able to do that, and we'll be able to give it a good scrutiny over it.
Yeah, I'm not saying that mental health issues aren't very significant, but I just think the other issues are, and we need that time for a broader discussion with the CCG.
Yeah, absolutely, and that is going to happen.
Okay, thank you.
Yeah, it's 2 items as well, which is giving it a good 2 bites of the cherry, if you like. David Martin, please.
Yeah, thank you, Chair. Yeah, recently, I can't remember which committee it was now, but it's one this year. It's been a long year. I asked Lucy Dadge from the CCG to look into the reticence of pharmacies to produce blister packs. So I don't know if you know what blister packs are, but blister packs have a row of medicine in Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday. They are delivered to patients by the NHS care workers and staff, and you know, to all sorts of patients, elderly and people with dementia, and especially in this COVID self-isolation period that this particular vulnerable group has been going through. I didn't get an answer because some pharmacies are apparently reticent to produce them. So I asked if there was a cost element, and I asked for an answer back to this, because it's obviously very important that all patients that require or need blister packs get them.
You're on mute, Keith.
I'm on mute as well.
I've spoken to.
Thank you, Chairman. Councillor Martin, on your behalf, I chased the officers responsible in relation to those blister packs at some length over the summer, and then again more recently. And I'm disappointed to hear that you've not had a response at all. I would suggest it might now be in the realm of Councillor Girling perhaps ringing up the officer concerned and getting a response directly, because I think your query has dragged on far too long, and you really ought to have had an answer by now.
Okay, I'm more than happy to do that. Obviously, you draft a letter, but yeah. Or is it phone call? Yeah, phone call. I'm happy to do that. Yeah, you happy with that, Councillor Martin? Yeah. Okay, John Duddy, please.
Yeah, thanks. I'm just going to follow up on Councillor Martin. There was a bit of a vogue amongst some chemists, I don't know if Boots comes to mind, where they were charging a £5 to the recipients of the blister packs in order to deliver them to people's doors. And it got a little bit of sort of adverse publicity because of that. It might be interesting to see if that is a practice which is ensuing, and whether it's affected, you know, people actually opting to have them because of the cost, etc. And I was just going to follow up again before my own point on what Muriel said. There was a case not long ago where there was a baby with a congenitally dislocated hip, and they couldn't get a scan done because of COVID. And then 6 months later, it showed that it had a dislocated hip. And then, of course, damage has been done that could leave it with a permanent limp, etc. But that is one of a myriad of scans, x-rays, investigations which have been lost. And I think it'll be really interesting to ask NUH how they've actually coped, and in particular whether or not there was satisfactory alternative areas where people could have had safe investigations that didn't all get lumped under the one big umbrella, that, you know, you just couldn't order anything, you couldn't get anything done. And if you asked for a routine x-ray or a routine scan, you were practically laughed at. Now, I mean, they did a little bit of it with the operations using the Spire Hospital and perhaps other private hospitals, but they don't seem to have grasped it in terms of the provision of the basics of services that were due to be used every day of the week. And as Muriel points out, it'd be very, very interesting to see if in the second wave we have any more resilience in doing that than we did in the first wave. We should have learned from the first wave and have the resilience to be able to do a normal service in the second wave. But I think we're going to find out that precious little was learnt. And I suspect it's going to be for a third wave, if we end up with one, that we'll learn it. But I think in November it'll be nice to ask the question. I think in December we've got something about the inequality of GP services coming forward. And I particularly wanted to highlight the possibilities of changes of service related to APMS contracts, which we're all aware of. And in Councillor Ruston's area in Hucknall, you've got Wyburn Medical Practice, etc. And these have to come up for tendering every so often, and the tender could go to outside providers. And what sort of impact would that have on the provision of service that exists within those type of areas? I know Councillor Martin has expressed interest in the medical services up in Hucknall, and Councillor Ruston's is the councillor for Hucknall. But these are practices across Nottingham which are alternative medical service providers, APMS. And therefore they are more vulnerable to takeover by outside interests like American conglomerates, etc. And therefore that could affect everybody's ability to work with an ICS, to work with our family neighbourhood practices. And I think that the threat to general practice by tendering of APMS practices and the effect that has on the delivery of services is something I would like to add into the December inequality that's been mentioned here, that's coming in December around GP services. It says briefing on equity of access, and it could be that we would tag on a request for the people who oversee that to give us an update, and we may have more specifics. Thanks.
Yeah, happy with that, John. I've got Martin right now, please.
Thank you, Keith. It's just to carry on from what John's just said. At that December meeting, the parity of GP services, I'd like to see a paper, if not someone to tell me in person, just what we're supposed to expect from a GP these days. I mean, we've got Muriel saying she's had good attention, she's seen GPs. I've got people on my patch who are having to wait 3 weeks for a consultation phone call. I mean, it's ridiculous. It's, you say, equity, equality or equity across the county gone crazy, really. I'd just like to know what GPs are expected to do. And I had to chuckle to myself when you can't get to see a GP, but when the shingles vax come and the flu vax come and GPs are getting paid for delivering those, get in straight away, no messing about. So I'd just like to know what we should expect, Keith. Thank you.
I think that's a great question, actually, Martin. I think one of the problems is GPs interpret COVID in their own way. They have to follow the guidelines, but it's how they interpret those guidelines, isn't it? And I think some have actually used COVID as an excuse for poor service rather than an excuse for actually providing a higher, better service, actually, because some have adapted really well. I know my GP service have been brilliant, you know, in terms of responding a lot quicker than they were before COVID, because it's done remotely now, unless you need to go in. I had an infection on my wound after the operation, and I went, you know, a phone call. They phoned me back in that morning, and then I was in to see them in the afternoon because they assessed it was important. So there is good service out there. There is good practice out there. But as you say, it's a bit hit and miss, isn't it? And I think a lot of it's down to the actual practice itself. So I think it'd be good to get whoever's responsible for making sure that GPs maintain a certain standard in, so that we can ask him what the hell or he or she is doing about it, and what are the consequences of not providing a good service. Because if there's no consequences behind that, then they'll just keep doing what they want to do, won't they? Okay, anything else on the work programme? You happy with that then, Martin? You got everything down? Okay, that's the end of the meeting then. Thank you so much, everybody, for the contribution. I think it's been a good meeting, and we've got our points across really well. Thank you very much, and I'll see you at the next meeting in November.
Thanks, everybody. Thanks, Keith.
Thank you.